Hello again, listeners. Our topic here is going to be serum sickness. This is a type 3 hypersensitivity reaction, and it also is one of the many ways that a patient can present with a fever and a rash. Now, in children, fever and rash is something that you are going to see very frequently. And so, serum sickness is one of the possible diagnoses, and so it's good to be aware of this. So our vignette here is a 5-year-old boy presenting to the clinic with his mother for a fever and rash of 2 days duration. 2 weeks ago, he had been seen in the clinic for sore throat and fever. Rapid strep test came back positive, and he was prescribed a 10-day course of Cefaclor, 160 milligrams every 8 hours, due to an established penicillin allergy. He completed the full course and the symptoms resolved completely. However, yesterday his mom noted a rash in his abdomen after he got out of the bathtub. This morning, the rash had spread to his buttocks, thighs, and arms. He was also running a fever and had one episode of non-bloody, non-bilious emesis this morning. Vital signs show blood pressure of 100/70, heart rate 125, respirations 20, temperature 101.4. Physical exam is remarkable for erythematous wheals over the abdomen, thighs, buttocks, and upper extremities, which he says are itchy. There is mild cervical lymphadenopathy, normal heart rate and rhythm, lungs are clear to auscultation. There is mild epigastric tenderness to palpation, but is otherwise soft and non-distended. Bowel sounds are normal. He is grossly intact neurologically. So our differential, this is a relatively straightforward. If you're aware of what serum sickness is, this is relatively straightforward. Now we're going to talk about, there is classic serum sickness in which you have to receive the serum, some kind of protein component from another species. However, there is also what's called a serum sickness-like reaction, or drug-induced serum sickness, which is more common because we don't commonly give animal serum anymore. We used to, particularly in immunizations, but we have fewer and fewer of those as we're beginning to replace them. So drug-associated serum sickness is much more common now. So, so this kid has a rash and a fever, and his rash is urticarial. So it's got the wheals, they're erythematous and itchy. That's urticaria, and that's what you can get in anaphylaxis, where you get the wheals as part of an allergic reaction. However, what stands out here is that he was taking this medication 2 weeks ago, and he finished it 4 days ago. Now, if he were allergic to Cefaclor, and remember, there is about a 10% cross-reactivity between the penicillins and the cephalosporins. If he had been allergic to Cefaclor, we would expect that he would manifest a reaction relatively soon after he started the medication. And he finished the 10 days, he was fine up until yesterday. And that is not consistent with an allergic reaction, with a type 1 hypersensitivity. Also, in addition to that makes us inconsistent with a hypersensitivity reaction, is that he's got a fever. Allergic reactions don't cause fever. So he's got a fever, he's got this urticarial rash, he's got some lymphadenopathy, again, something that you don't see with an allergic reaction, and he's got this epigastric tenderness. And these are all signs consistent with serum sickness. Another sign that's common in serum sickness that you may have seen in this patient, but we happened not to see it in this patient by chance, would be arthralgia. So this is just a better view. This is not really great resolution, but this is urticaria. So you get those slightly elevated wheals. They're red, erythematous, and the patient will be itching them. So this is just pointing out the important features here. All right, so this will be what we'll talk about just briefly, the epidemiology. We'll talk about the pathogenesis. This one's unique compared to some of the other things we've talked about, in that this is a type 3, an immune complex mediated hypersensitivity. We'll talk about the clinical manifestations, the diagnosis and management, and then some of the complications. There's really not that many, they're pretty rare, and prognosis. The annual incidence of serum sickness is decreasing. Like I said, we're using fewer drugs and vaccines that contain animal serum, and really our drugs are just becoming more sophisticated and having fewer side effects, particularly side effects that would happen because you are exposed to animal serum. So we're not seeing this as frequently. However, there are drugs that can cause serum sickness. Now, that's not technically serum sickness. It's serum sickness-like reaction or drug-induced serum sickness. But it looks clinically indistinguishable, identical to classic serum sickness. So it really doesn't matter. We consider them one and the same. But technical, true serum sickness is decreasing in incidence. As far as drug-induced serum sickness, that's probably not decreasing. That's probably either increasing or staying the same, since these are common drugs that we use. So the particular drugs that are commonly implicated are antibiotics, especially the penicillins and cefaclor. Any of the cephalosporins can be involved, but cefaclor, it's a second-generation cephalosporin, is very commonly involved in serum sickness-like reaction. Other drugs that can be involved include some of the anti-epileptic drugs like dilantin and carbamazepine. And then another important class of drugs that really would be considered under the animal serum class, so the true serum sickness would be some of those polyclonal or monoclonal antibodies that we use for some of the autoimmune diseases. We'll talk about that. Antibiotic-associated serum sickness-like reaction is more commonly described in patients under the age of 5. So in the patients that we see serum sickness or serum sickness-like reaction, they tend to be under the age of 5. Again, because we are not using animal products as much. So because the typical patient that comes in with serum sickness is given their prescribed drugs, and they're more commonly under the age of 5, in that case, we will see disease that manifests as serum sickness more commonly in patients under the age of 5. Hopefully that makes sense. So because serum sickness-like reaction happens more in patients under the age of 5, just your general, if you consider serum sickness and serum sickness-like reaction as a single entity, then you're going to see these in general in patients under the age of 5, simply because there's so many more patients prescribed antibiotics like cefaclor and penicillins than there are patients who are receiving the monoclonal antibodies or antitoxins or hormones from other species. So that's why it's more common in younger patients. But you can see it in any age. So true serum sickness is due to the administration of drugs that contain proteins from other species. So this includes antitoxins, so tetanus antitoxin, anti-rabies serum. We don't really have to give this that much. I suppose you could give you might be giving tetanus antitoxin to a patient who stepped on a nail and has not been immunized to tetanus in the last 5 to 10 years. But we just don't see this that much. Not as often as we give antibiotics, obviously. Anti-rabies serum is the most, if you're given, out of all these things that you can possibly give a patient, these things listed here, and then all of the drugs, anti-rabies serum is the most likely to cause serum sickness if you're given one of these many things. Antivenins, so there's tons of those. That would be like the antivenom you might be given for a snake bite or a spider bite. Hormones from other species, so in particular here antithymocyte globulin and OKT3. These tend to be given in patients who have received a transplant. The antithymocyte globulin we usually get from either horses or rabbits. OKT3 we usually get from mice. Streptokinase, this comes from bacteria. That's given to break up clots. Vaccines, so in particular here, MMR, the rotavirus vaccine, and varicella zoster vaccine. And those are usually either porcine or bovine in origin. And then the polyclonal, monoclonal antibodies, those include things like infliximab. We give that for patients with rheumatoid arthritis and Crohn's disease. That comes from mice. Omalizumab we get from the Chinese hamster. Omalizumab is given for allergic disorders. And then rituximab, which is used for certain blood dyscrasias. So I believe certain lymphomas. Okay, I think that's all I wanted to talk about there. All right, serum sickness-like reaction is clinically indistinguishable from serum sickness and typically is due to drugs, particularly antibiotics, as we mentioned. The risk is correlated proportionally to the dosage administered. So the higher dose you use, the more likely you are to develop serum sickness from the drug. Certain infectious diseases can cause a serum sickness-like reaction, in particular here hepatitis B and infectious endocarditis. And what's happening here is that you have circulating antigens, antibodies attack that, and you have this antigen-antibody complex, which then that's an immune complex, and that can result in the serum sickness-like reaction. So here's a list of all these drugs that can cause serum sickness, but the most common are penicillins, cephalosporins, and antiepileptic drugs. But there's a whole list of things that can cause them. So the pathogenesis, this is a type 3 hypersensitivity reaction, which involves the formation of immune complexes. Basically what happens is that you're administered an antigen, either be it from animal serum or drugs, and that antigen administration produces a rapid IgG response, which then attacks the antigen, and you have this immune complex, which is just antibody and antigen connected to each other. Now, that having been said, the complexes that these immune complexes, there are special properties to them as far as the ones that cause serum sickness. So you produce antigen-antibody complexes, immune complexes all the time. Why are you not getting serum sickness all the time? Serum sickness is actually relatively rare. And the reason is because it's kind of like a Goldilocks phenomenon. So the antigen can't be too small, because if the antigen is too small, then it's not going to adhere to the wall of the vasculature. Yet if the antigen is too big, then it's going to be eaten up by macrophages, and it's going to go out through the reticuloendothelial system. So it has to be just right. It can't be too big or too small. And so that's why there are a limited number of things that can cause serum sickness. The generalized inflammatory state, so what happens here is that you get these complexes, they adhere to the endothelium of the vasculature, and that is going to initiate the complement cascade, and that's going to result in inflammatory response, and that leads to systemic manifestations, including the fever and malaise, as well as the myalgias and joint pain. Symptoms will typically manifest 1 to 2 weeks following the exposure to the antigen. However, if you've been exposed to the antigen before, and now you're being exposed to it again, the manifestations can come out a lot sooner. So for instance, this child that we saw, it took him about 10 to 14 days to develop his symptoms of serum sickness, and those will resolve. But if he were to get cefaclor again, which he shouldn't, the patient should know not to take that again, but if he were to get cefaclor again, his symptoms of serum sickness would come on a lot faster the next time. So this is basically what's happening. You get the serum, or it could be the drug. Really, this is just the antigen. And once that happens, then you start to make antibody. So the drug or the serum is only in your bloodstream for a limited amount of time, and then you start to make antibody. And it's that period while you still have the serum proteins or the antigen in your bloodstream, and you also have antibody beginning to form. So you can see here that when you have both, then you can form your immune complexes, and that's going to cause serum sickness. Ultimately, we withdraw the agent as part of our treatment for serum sickness, and so you no longer have that antigen, and then those antibodies, they're harmless. So this is only a problem when you have circulating antigen plus the circulating antibody to that antigen, because they together form the immune complex. So once that antigen has been withdrawn and you no longer have that antigen circulating, then the serum sickness goes away. And that's why this is self-limiting. So this is just showing the mechanism of a type 3 hypersensitivity reaction. You get the immune complex, it adheres to the lamina of the endothelium, and then it initiates the complement cascade. You recruit things like neutrophils, and that releases proteolytic enzymes that then damage the lining of the capillaries and arteries. The manifestation. So fever and malaise is almost always going to be present. The study I saw said 100%. So you're always going to have fever. Arthralgia is very common. We didn't see it in this patient, but 3 in 4 patients will complain of arthralgia. You can also see things like myalgia and lymphadenopathy. The cutaneous symptoms, this one's also very important because it occurs in more than 9 out of 10 patients, is the rash. Now the rash is going to vary, but typically in the majority of cases it's urticaria, like we saw in this patient, which is an erythematous wheal rash that is itchy. But you can also get things like erythema multiforme, which is a sort of heterogeneous kind of rash. You can get petechiae and purpura, and with the petechiae and purpura, you get that usually after you have urticaria, and the petechiae and purpura develop over the top of that. And the reason there is because you have immune complexes that are forming and lodge into the capillary and ultimately cause destruction of the capillary, and then you get bleeding into the skin. And that causes the petechiae and purpura. So that will develop usually a little bit later on. Headache and blurred vision are not uncommon. As far as pulmonary symptoms, they tend to be rare, but you may have dyspnea and wheezing. Pleuritis can develop, but that's quite rare. Cardiovascular manifestations, these are really the severe manifestations. If you do have very severe serum sickness where we may need to admit the patient to the hospital, pericarditis and myocarditis, these would manifest as chest pain. GI complications or GI manifestations include just general complaints, so usually just abdominal pain, nausea, vomiting, diarrhea, not really severe problems, but it is common. 67% will complain of some kind of GI problem. And then as far as neurologic problems, they're very rare. Peripheral neuropathy, optic neuritis, CN palsy, Guillain-Barré syndrome, they're all very rare. These are typically are more feared complications out of serum sickness, but they're quite rare. So what you should remember are these ones in red. If you don't, I mean, it's good to know all these, but you should remember these ones in red. So fever, joint pain, rash, usually urticaria, and then general GI complaints. So this is urticaria developing. Typically, the urticaria will start out in the abdomen, and then it will migrate towards the buttocks, and then ultimately up the chest, and then to the extremities. So it's kind of, it starts out in the middle and kind of diffuses outwards. But it can vary. It's not always that way in every patient. Again, you see urticaria here, particularly over the abdomen, the upper thigh, and then you can see it also extending to the upper extremity. So other things that you may see, so I already told you about the lymphadenopathy. That can be regional, or if the patient had gotten an injection, so like tetanus antitoxin or something like that, then the lymphadenopathy will often be regional to where that injection is. You can also get edema of the face and neck. As we're going to see, you can get some mild kidney problems from serum sickness, and that's just due to immune complexes forming in the microvasculature. Not severe and generally not permanent, but they can develop. And so you can get mild proteinuria, which can cause a little bit of edema in the face. It doesn't take much proteinuria to get edema in the face and neck. All right, so with a high index of suspicion, the diagnosis can be made clinically. There are a couple things we want to rule out, and we'll talk about that in the differential, but for the most part, this is a clinical diagnosis. Now, if you were to think of other things and you ordered labs, then these are some things you might see. So on the CBC, typically there's a mild thrombocytopenia. Reason here is because you get a little bit of thrombus formation in the microvasculature, and so that will reduce the platelet count a little bit. The white blood cell count may be low or slightly high or normal, so it really doesn't help, but it may be disturbed. And then if you were to do a peripheral smear, you may see increased plasma cells. If you get chemistries, generally you will see some kind of elevation in creatinine, not severe, but the creatinine will be higher than baseline. Sed rate will be elevated, of course, as an inflammatory reaction, but it really does not tell us anything. On urinalysis, you will see some abnormalities, microscopic hematuria, mild proteinuria, just reflecting that there is microvascular disruption due to the immune complex deposition. Your C3 and C4 will be decreased. Typically, we don't go that far, though, as far as labs. But like I said, if you were to get them, then this is what you'd see, but generally this is a clinical diagnosis. All right, so our differential. There are some important things in here that you want to differentiate out. And the reason is because these are things that present with fever and rash, and there are so many different things that cause fever and rash. Now, the way that serum sickness presents, we can eliminate a lot of those things, but there are two things that I want you to be aware of that you want on your differential if you have a child with fever and particularly a purpuric rash. So, like I said, serum sickness tends to be an urticarial rash. However, later on, because you get microvascular disruption, you can get purpura, particularly palpable purpura. So, one of the major things we want to differentiate out is Henoch-Schönlein purpura, which is one of the more common causes of palpable purpura in a child. So it's quite similar in etiology. Henoch-Schönlein purpura is a systemic disease. It particularly affects the skin, but also commonly causes joint and abdominal pain and fever. So that's very much like serum sickness. And also, if you think of the mechanism, Henoch-Schönlein purpura is due to IgA immune complexes. So it shares a lot of similarities. One of the things that makes Henoch-Schönlein purpura different is that it will never present with an urticarial rash. It will always be the palpable purpura, it won't be on the context of, you won't get urticaria first and then purpura. Even in serum sickness, you're not always going to get purpura. But Henoch-Schönlein purpura will always be palpable purpura. Also, Henoch-Schönlein purpura tends to follow an upper respiratory tract infection. Whereas with serum sickness, it tends to be associated with a drug or with some of those serums, or in rare cases with hepatitis or endocarditis. So you should consider the history and natural progression of the rash. With Henoch-Schönlein purpura, the outcome is a little bit different. So 1% of patients with Henoch-Schönlein purpura ultimately will go on to develop irreversible renal damage. That's the IgA nephropathy. And remember that IgA nephropathy is the most common cause of glomerulonephritis in the world. You treat Henoch-Schönlein purpura the same way generally, for the most part, as serum sickness, and that's just observation with optional prednisone. Kawasaki's disease, this is a big one. You can't miss this one. So this is seen in very young children. 85 to 90% of the cases occur in children under the age of 5. This also will present with a fever and a rash, but it's a little bit different. So Kawasaki's disease is actually an autoimmune disease that affects the medium-sized vessels. And the most feared complication of Kawasaki's disease is the coronary artery embolism, and that can cause death. So this is why we need to make sure that we're catching this, if this is indeed what it is. Now with Kawasaki's disease, the rash looks very similar to serum sickness. It looks kind of urticarial or erythema multiforme. But with Kawasaki's disease, what you're ultimately going to get are these oropharyngeal signs, which include that classic strawberry tongue, which is an erythema of the tongue, and then the little like pits of the strawberry that you see on the tongue, that's actually your little taste buds. And ultimately, this is caused by a necrotizing microvasculitis along with fibrinoid necrosis. You also see fissures of the lips or crusting of the lips, and sometimes there can even be bleeding. So oropharyngeal signs in Kawasaki's disease. The fever in Kawasaki's disease tends to be much more severe than the fever in serum sickness. So it's a very, very high fever in Kawasaki's disease, usually 102, 103, 104 degrees Fahrenheit, and it's very refractory to things like acetaminophen or ibuprofen, whereas with serum sickness, typically that will resolve the fever. Okay, so remember that with Kawasaki's disease, there's the oropharyngeal symptoms, conjunctival injection, very refractory fever, but a similar rash. Important to make sure that this is diagnosed because all of these patients are going to need, they're going to get mandatory echocardiograms looking for any kind of possible aneurysm of the coronary artery. With Kawasaki's disease, without treatment, 1% will die. And if you treat it, that's about 0.2% or so. Okay, cryoglobulinemia is similar in presentation to Henoch-Schönlein purpura. So you get a purpuric rash. It's also a disease of the vessels. It's also associated with these sort of immune complexes. So it shares some similarities. Most commonly, you're going to get a purpuric rash. However, you can get an urticarial rash like you would in serum sickness. But typically, with cryoglobulinemia, if you get an urticaria rash, a lot of times the patient will tell you it's induced by the cold. So in the winter, they go outside, and then they come in and they've got urticaria. That's what you would tend to see in cryoglobulinemia. In some cases of cryoglobulinemia, cryoglobulinemia is divided up into three types. So the type 1 cryoglobulinemia, that is the one that's associated with Raynaud's phenomenon. You don't see that in all cryoglobulinemias, though. Unlike serum sickness, respiratory symptoms are more common. So you see it in about 40 to 50% of patients. They'll have dyspnea and pleuritic pain. Whereas fever is a little bit less common than in serum sickness. Microscopic polyangiitis, this is generally going to be in older patients over the age of 50. Fever is also common here, but again, less common than in serum sickness. Here you can see things like mononeuritis multiplex, which you can see in serum sickness, but it's much more rare. And then weight loss, because this is a systemic disorder. And this is more chronic than serum sickness, which will resolve on its own. And that really helps you separate cryoglobulinemia and microscopic polyangiitis from serum sickness. Okay, these other ones don't look a lot like serum sickness, but if you don't have all of the typical symptoms of serum sickness, you can get, you may get confused. So dermatitis herpetiformis is a pruritic rash, but it is blistering. So that is a little bit different. Its symptoms are strictly limited to the skin, so you're not going to get arthralgias or anything like that. The patient may have a history or symptoms consistent with celiac disease. You should do a mental word association between dermatitis herpetiformis and celiac disease, because if you ever diagnose dermatitis herpetiformis in a patient, you need to ask them about do you have problems, GI problems like diarrhea or foul-smelling stools or gas, especially after eating products with wheat. Because if that is the case, then they need a GI consult for a workup for celiac disease, and they should be advised in the meantime to avoid products with gluten. Infectious mononucleosis has a lot of the similar symptoms to serum sickness, like fever, malaise, and myalgia. But with infectious mononucleosis, we see the pharyngitis and lymphadenopathy all the time. That is a major part of mono. Mono is often described as a triad: fever, pharyngitis, and lymphadenopathy together. And it's typically in a younger patient, usually teenage years. Management of serum sickness, because it's a self-limited disease, we typically just do supportive care. We don't have to do anything other than that. There are a small minority of cases where you may want to give prednisone, but the majority of cases we just manage outpatient with a follow-up in a couple weeks. So the most important thing that with serum sickness, and it's pretty obvious that you want to do this, but you want to withdraw the offending agent. So you want to stop whatever drug they're on. So if they're on an antibiotic, even if they're during the course of that antibiotic, you want to switch them to a different antibiotic. So you withdraw the offending agent. NSAIDs can be given for fever and joint pain. Antihistamines can be given for the urticaria and the itchiness. Both of those can be over the counter. Follow-up should be done in 2 to 4 weeks just to make sure that everything's resolved. In severe cases, so patients, for instance, with endocarditis, with severe pleuritis, with neurologic involvement, you can give them steroids. So it's really going to be a clinical judgment call, but some patients can get corticosteroids if it's severe enough. Patients with major comorbidities, so very, very young patient, I would say maybe under 1 year of age, or very old patients, so 65, 70 years of age older, or patients who are just in general sick, or patients who are immunocompromised, they should be hospitalized. It's, again, here, a clinical judgment call. There's really no hard and fast rules, but you may want to admit patients for observation if they are just in general sick or have comorbid conditions. Severe symptoms, particularly endocarditis, you want to admit them for observation, or if the diagnosis is unclear. Complications out of serum sickness, generally none. The vast majority of patients will resolve on their own without any kind of treatment other than removing the offending agent. Typically, this happens within about a week or two after the initial onset of symptoms, but they should definitely be resolved within a month. If they're not, then you need to work them up for an alternative diagnosis. The most common major complication of serum sickness is peripheral neuropathy, as well as other peripheral nervous disorders, so like brachial plexus neuritis, optic neuritis, cranial nerve palsies, Guillain-Barré syndrome. Very rarely encephalomyelitis, which can be severe and life-threatening, but that's extremely rare. Acute renal failure can be a sequelae, and this is why some physicians will prescribe prednisone to all patients with serum sickness, but that's not supported in the literature. Glomerulonephritis, angioedema, and anaphylactic shock have been described as complications of serum sickness, but again, these are very rare. So as far as prognosis, like I said, it resolves on its own as soon as the agent is withdrawn. Very few patients will have any long-term sequelae. Even though this is a very unpleasant syndrome, it very rarely has any long-term implications. Occasionally, there have been reports that have shown mortality from progressive glomerulonephritis or severe neurologic complications, which namely is going to be encephalomyelitis or Guillain-Barré syndrome. The progressive glomerulonephritis, what that is damage to the kidney due to the immune complex, and it damages those small arterioles that form the glomerulus. Patients should be advised to avoid the drug in the future and just regard it as a drug that they are quote-unquote allergic to. So even though it's not like an anaphylactic reaction, whenever they're asked what drugs are you allergic to, they should include this drug. You should also make a note on the patient's chart indicating that they took X drug and they got serum sickness. So that drug can be avoided in the future. And that is everything.